Hi, everyone, and thank you for joining us for ACPE's four-part webinar series on responding to domestic violence and situational grief, a primer for mental health and spiritual care professionals. Today, you are joining us for the second part in this four-part series. And so today's piece, the focus is on responding to domestic violence and an overview. And our speakers are Dawn Starry in San Diego and Dr. Claire Bamberg in Vermont. Welcome.
Thank you. Go ahead.
Okay, so hi everyone. Welcome back to the second week of our series. Last week, Dawn and I presented just kind of an overview of what we'd be covering along with resources. Today, Dawn's going to present more about domestic violence and intimate partner violence. I will go the third week. I'm an ordained minister in the United Church of Christ, and I've been 37 years in that capacity. I'm a licensed mental health professional in 3 states and certified mediator and a certified professional coach. So when I enter and take a look at grief, it's from all various aspects. And next week, I'll be walking through the grief cycle, resources, how to manage those very first few moments when you realize this is what you're dealing with. And especially when I work with first responders when they're on the scene and they realize that there's been a demise. So just to preview that, and then the fourth week we'll do some commonalities, differences, and where to go from here. There you go, Dawn.
All right, perfect. Thank you, Claire. Good morning. Well, it's morning in San Diego. Good afternoon. Hi, everybody. So I want to say in advance that I woke up this morning with a cold, so I might be sneezing and coughing and all those things. But I'm just fine, but I wanted to let you know should any of that happen throughout. So before I go into the slides that I have for this morning, I wanted to let you know, and I'll show you the email address in a moment for Janelle. But if you have any questions during the session, you're welcome to write those in. There's a Q&A that you can click on, and you can write in your questions, or if you have any comments, anything you want feedback on, send those throughout my time of talking. But if you think of something after the fact, you can email Janelle and I'll show you all that email in just a minute, like I said. I wanted to introduce myself again. So I am a pastoral counselor. I have been working as a pastoral counselor for a little while now. And for about 10 years, I've been doing primarily trauma and trauma recovery work with refugees and asylum seekers who are primary and secondary survivors of torture in their home country. And in that work, I have encountered several times incidents around domestic violence and intimate partner violence, which I'll explain the difference in those definitions in a little bit. So, and it's sort of what has happened to me is kind of like what we're talking about for the work that you guys are doing, in terms of like, I enter the space ready to talk or prepared to talk about one thing, or thinking my client's going to address one thing, like the signs and symptoms that come with having been a torture and trauma survivor. And then they'll begin to talk about, once a rapport has been built, they'll say, well, also, and then today I'm going to offer a case with a client who was in the midst of a domestic violence scenario where she, we were talking, and then she came and she started telling me about incidents that were happening in the home with her children present. And then I'm going to talk to you about a case that I just recently, really just in the last couple of months, of a client who started talking about incident of domestic violence in her marriage that she had left. But so both cases, that they were actively happening, and one that is still affecting the client, but that she was no longer in the situation. So that's a little bit about my background. And let me see, I'm going to go now and let me pull up the slides and share. Okay, so here is, it's just taking a second here, it looks like. my computer's moving slowly. But here is Janelle's email that you're welcome to email her there. There we go. And if you have any questions after we get off of the webinar today, you can email Janelle there. But again, throughout the session, please feel free to email. There's a Q&A button, and you can just type in your messages like you guys did last week, which was great and contributed, I think, tremendously to the webinar. So please feel free to do that throughout. So just some objectives for this morning or this afternoon, today, together. I'm going to define the difference between domestic violence and intimate partner violence. You'll see that they overlap. We'll just briefly talk about trauma, defining that, and then learning best practices and resources when responding, and then exploring the importance of self-care as well as additional resources. So my understanding is, for the most part, who is on the webinar are chaplains who are present in a situation working with a patient, as well as chaplain educators, and who are educating those who will become chaplains or are in the process of becoming chaplains. And so it seems that you'll have both moments where, like, you're with somebody and you may not be with them again, and then you'll have times where you're with a student who you might be spending more time with, that you might have a longer period of time with. So there might be slightly different responses to both. Okay, so I wanted to start with the myths about domestic violence and intimate partner violence. And again, I'll go into a deeper definition of both of those. But I think it's really important to talk even kind of about our unconscious bias as well as the myths that go with it. So sometimes I've heard that there's this sense that domestic violence only happens in poor communities with uneducated people. So that is absolutely not true. It does not discriminate. It does not know boundaries. You see it in any socioeconomic background. You see it across race. And then I'll go to the next bullet really quick, is that it's not always a man who's perpetrating against a woman. It could be a woman perpetrating against a man. And then the first bullet said, the sense that it could never happen to me. I remember talking to some friends where there was an incident that came up where we were talking about somebody who had just left an abusive marriage. And after the conversation and that person was no longer present, the one friend said to me about her daughter, "Oh, well, that would never happen to my daughter." And so we don't know that. We don't know that that's true. People don't enter into situations and the abuser says, clearly that they're going to be abusing. So these things happen over time, and it's about control and controlling the person. And so again, it doesn't discriminate. So there's the other myth that if a person stays in a situation, it must be a tolerable situation. That too is not true. People stay for a variety of reasons. And some of you might remember a couple years back, there was an incident with a football player who had, I think it was in an elevator, so it was caught on camera, where he had hit his then fiance. And so then there was all this talk about, well, why was she staying in the situation? So there was this hashtag that came about, why I stayed. And I was looking at that again yesterday because I wanted to mention it. And the reason, looking at some of the reasons, which were, I was scared, I was isolated, I was alone. I had made a commitment to this person and I thought I needed to stay it out. I didn't want to break up my family. I didn't have means to leave. I didn't know where to go. So there are many, many reasons why people stay in situations of domestic violence or intimate partner violence. And then there's this sense too, and I think, we hear this not just with domestic violence, but with the around conversations around sexual assault, and this has been happening a lot too. I think this conversation with the Me Too movement, where someone will say, well, he or she hasn't been mean to me, he or she hasn't done anything harmful or hurtful to me, so maybe this isn't happening. Sort of like dismissing what the survivor is saying because the person has not seen that side of the abuser. So there is this sense of Dr. Jekyll and Mr. Hyde, where out in the community, the abuser might be very charming and well-liked. And at home, it's a very different story. So I wanted to put those out there for you for just some things to have in mind as you encounter people who are survivors of domestic violence and intimate partner violence. Okay, so moving on with the definition of both. So these terms are sometimes used interchangeably, domestic violence and intimate partner violence. And intimate partner violence is a relatively new term. And domestic violence, I mean, really in the grand scheme of things, is a relatively new term as well. But it's just really in recent years that I've even begun hearing the term intimate partner violence. So domestic violence, it can be a broader term, one that includes others in the home, so children, others living in the home. Maybe there's a multi-generational situation where there's like grandparents, parents, children living in the same space. And domestic violence is a pattern of abusive behavior in a relationship that's used by one partner to gain or maintain control over another person in the home. So that could be a husband and wife, a mother with a child, or a husband with the mother and then the mother with the child. And there's different types of abuse. This is an important one too. So often I think my experience has been that when someone thinks about abuse, or when I have conversations with people around abuse, it's the sense that there has to have been some sort of violent physical act, as somebody must have been hit, somebody was sexually assaulted. But that is certainly can be a part, but abuse can also be neglect, as well as emotional and psychological abuse. So repeatedly putting somebody down, repeatedly, taking away autonomy, so taking away their car keys, not letting them have access to the bank accounts, monitoring their whereabouts, whether through, following them with an app that follows their movement, or monitoring their email. So it's not just physical abuse. Now, that may be what you see in a hospital, because maybe that's like what a person has come in for, but they maybe have come in for something else, and then this comes out as you're talking with them. So it's different types of abuse. So intimate partner violence is more specifically between two intimate partners who may or may not be living in the same home. So it could be a boyfriend and girlfriend, seeing these incidents in high school as well. So an abusive partner, and they're not living together, but there's still the violence, there's the control, there's still the implications that come if they break up, and the abusive partner, stalks the other partner. So I think of intimate partner violence as a slightly, it's less broad. It's a smaller term in terms of who's involved with that. But again, those terms are used interchangeably, and they can be used interchangeably. But domestic violence is broader, with more people that could be involved. Okay. So trauma, I'm not going to spend much time looking at this definition, but I did want to put this out there, especially because it was one that I thought was was a good definition. It's from the American Psychological Association. And trauma is an emotional response to a terrible event, like an accident, rape, or natural disaster. And immediately after the event, there's shock and denial. That's a typical part of it. And longer-term reactions include unpredictable emotions, flashbacks, strains in relationship, physical symptoms like headaches and nausea. And this, of course, can result in post-traumatic stress disorder or acute post-traumatic stress. And so thinking about I'm thinking especially right now about the chaplain educators who may, maybe you have somebody who is in CPE, and so they've had, maybe they're out in the field, they're doing their work, and they come back and they start sharing about something that was triggered in them because of the work that they were doing in a hospital setting, let's say, for example. And so that could trigger the unpredictable emotions, the flashbacks. And for somebody who's having the moments like those flashbacks, I've heard clients repeatedly say, and you may have heard this too, is those really feel like movies. It's as if it is happening in front of you again. It's as if for the person, they go right back to when the incident occurred, even if they're out of the incident, even if it's not ongoing right now. So these are, those are some things for you to look out for as these things maybe come up for you in the work that you're doing. So I talked about this last time. We're moving on to best practices, and responses. And I was thinking, geez, Dawn, you're really hammering home this point about resisting the urge to touch somebody. And I know why I'm doing that, and I will explain that in a moment. But it's very natural to, we're compassionate people. I'm a compassionate person, and it's natural for me to want to like hug somebody or touch their hand, especially when they've told me something that's really, really difficult. And maybe it's difficult for me to hear, and so maybe me even touching them is a way for me to sort of feel calmer. And I know I know why I'm talking so much about this, and it's because I mentioned last time that a lot of the work that I do is done through translation. So there are interpreters that I work with, and while some interpreters are amazing and they do an amazing job, some on the other hand have some room for growth, as we all do. So what I've seen recently, just in the last few weeks, I had a client where at the end the interpreter was like, "Oh my goodness, thank you for sharing," and then hugged the client without asking first. And then I had another one recently where a woman is a sexual assault survivor, and the interpreter, after hearing that story, had reached out and grabbed her hand without asking. And so part of trauma-informed care is not, a large part of it really is empowering the person that you're working with. And a part of that empowerment is only asking permission to touch somebody, because being touched might remind them of what they've gone through. So that's why I'm really thinking about it. That's why it's in the forefront of my mind so much right now. The next point I want to make is for you, for the person, for those of you on this webinar who may face an incident where you start talking with somebody and then this very difficult story comes out about either they're in the midst of domestic violence incident, a scenario in the home, or something triggered a memory and they're talking about what they went through in the past. I apologize. I was about to sneeze, so that's why I was delayed there for a second. Sorry. The important thing is to remain calm. Do the techniques that perhaps you're teaching other people to use with yourself, using the deep breathing, maybe doing your body scan, like, going over in your mind how you're feeling. When I hear something that's really difficult, I feel it in my stomach, and sometimes I get a little wobbly in my knees. So making sure that I'm remaining calm, I'm breathing deeply, maybe sort of talking to myself, reminding myself like, okay, just be present to this person, and so that I don't go into a mode where I'm feeling really anxious and that maybe I would say something that would be not helpful. And then, so just kind of getting your grounding in the moment, And then really assessing for safety. So, for example, if you have a patient who's telling you that, and I think this was one of the examples last week, is that there was a patient whose daughter was in the home, in the patient was saying that they were a survivor of domestic violence and they were really concerned for their child who was under 18. So it's important to assess the situation. Remember that you are a mandated reporter. So if you hear of an incident involving a child who's under the age of 18 or an elder who's 65 or older, you have to report. There's no option but to report. If you're working with somebody between the ages of, who's 18 and before they turn 65, then that's different, right? You are not mandated by the state to report. However, you do need to assess the situation, ask if it's safe to go home, ask if they have a plan in place in order to leave the home. Do they have resources? Where will they go? Thinking about an incident of somebody that I knew, they were able to go to their family. And actually the case I'll tell you about later, when she did leave, she was able to leave because she was able to go to her family. And so the family took the client in, and then she was able to leave the abusive marriage. So have you told anybody? Is asking the patient this, or if it's a student, does anybody else know about this? Is there anyone else you can talk to? Do you have a plan in place? And so I know that in my experience, if I'm in the middle of a crisis situation, I need to have heard this information more than one time, so it's sort of like ingrained in my brain. So what Claire and I were talking about is that we want to make sure that everybody has these resources so that you can, so these are tools that you're given, so that these are things that you've learned, so when you're in the moment, you can have this information sort of at the tip of your tongue or in the front of your brain to remember how to assess. So assessing for safety, asking if they can go home, asking if there's a plan in place, assessing if there's any minors or if there are anybody who's over 65 and needing to call and report. But then also being able to offer resources if a person would like resources. So knowing, would they like to know about a shelter that they could go to? Would they like to talk to the social worker who is in the hospital? Again, doing this all very calmly, just sort of offering this to them. And then a person can refuse. If they don't want that information, they of course can refuse, but it's important to have offered it to them. Then, okay, so using, again, when I was talking about in trauma-informed care, which we're not going too deeply in today, but using affirming language, thanking the person. I always think it's really important to thank the person for sharing with you, having had the confidence to share, because these are difficult stories, and just showing gratitude. And I say that to my clients all the time, thank you for letting me be a part of this with you and to journey with them. And this is where really the presence, the ministry of presence that I imagine that chaplains do quite well, just being present to the person, pulling out their strengths, looking at, for example, with the case with the mom who was worried about her daughter at home, could really point out, like, what a caring, loving mom you are, that you're in the hospital and you're thinking, of course, you're thinking about your child and your child's well-being, and we're going to do everything we can to protect your child, and to really affirm the strength of the person that's sharing. So even just saying, it takes courage to share this story. These are difficult stories that are often fraught with anxiety and shame. You know, even though we're doing, I think, a better job of having these conversations in society, it's still things that these are difficult conversations for people to have. People don't tell their family members that they're going through. They don't even tell their closest friends that these things are happening. So really affirming the strength and the courage that it takes to share, and letting them know that when they're ready. So if somebody refuses help, you know, you're not mandated to call, they refuse help, just reminding them that the resources are there, and they can call the hospital, they can call 211, which is a line, a phone number that they can call to get resources after the fact. You know, just really affirming, I can't say it enough, just really affirming their strength, their strengths and their courage to share, I think is so valuable when doing this work, really working to empower a person. And if it feels appropriate, you know, if somebody is sort of like their anxiety levels come down, they're not as panicky, even asking, you know, have they thought about what they would like to do? Have they thought about what steps they would like to take? If it feels appropriate to ask that question. If somebody's feeling very raw and is in a very difficult situation, maybe they aren't in the space to think about that. But you can certainly ask that question. You know, what do you think you might need? Or what steps do you feel like you're ready to take? Again, giving power back to the person, giving them some control, especially since domestic violence and intimate partner violence is about a loss of control. So giving control back to people in a way that lets them look at their needs, and giving them back a little bit of that sense of control in their own life. Step by step, it will be a process for them as they move out of this situation into a different situation. There are many, many steps that'll have to be taken, but even just seeing the person, really seeing them and hearing them and listening to them, and then offering back, you know, these are those skills too, of like, well, what I'm hearing you say, and it sounds like, but it's so vital to hear them and see them, because somebody who's a survivor or who's in the midst of domestic violence or intimate partner violence is not being seen or heard. They're not being valued in the way they should be in their relationship. So to provide that humanity and that compassion, I think can go a very, very long way. Okay. So I wanted to offer my case studies. I'm going to go back so you can see me while I share these. So I'm going to share the two case studies that I have. The first one is a female. She is Iraqi. She was recently resettled. When the incident happened, she had been recently resettled in the United States as a refugee. So she'd come as a refugee with her husband and her two small children. They were little boys. I want to say they were like 4 and 7 at the time, but they were little. One was in elementary school, the other was not. And she was in her mid-30s. She had been coming to me. She was very, very stressed. And so I'll give a little bit of background. And refugee and asylum seekers have been in the news a lot lately, so you maybe are aware a little bit about this. But it's a very difficult process. So even when a person comes to the United States, they've been vetted by the United Nations. They're good to go. They come. A resettlement agency helps them find housing. They can help get the kids into school, get them on, in California, so Medicaid in California is called Medi-Cal, get them Medi-Cal services, if they need food stamps, you know, maybe help with job prospects, things like that. But it's still very difficult, and San Diego is a very expensive city. So even if people were well educated, they aren't necessarily able to get those jobs. so for example, several of my clients' husbands, I'm most often with the women. Sometimes I have male clients, but several of my female clients' husbands were engineers back at home, or I have a client right now who's a teacher, but they're not credentialed to do that work here. So thinking about, okay, so this woman in her 30s was able to, I'm hearing that it's bad. I just got a message that it's bad audio. Is that still the case?
Dawn, I think it's only for that one person.
Okay.
The ACPE office is fine, and I'm hearing you perfectly.
Okay, thank you, Claire, for telling me that. Okay, so with this woman that I was working with, she'd been very, very stressed, and like I said, this process is a stressful one for people, but she seemed like additionally stressed. She was talking about just how inhumane the refugee resettlement process was, and she just was at her wit's end. So I was addressing the symptoms as they came. We were talking about coping and acculturation, entering into a new country with new cultural expectations. So just sort of processing what she'd gone through. And then one day I was with her, and this was through interpretation as well, with an Arabic speaking interpreter who's also Iraqi, and who, as it turned out later, told me that she herself was a survivor of domestic violence. So she was triggered in that moment. So we were walking because that was the easiest. She couldn't be at home. She didn't want to be at home. And I often do home visits with people. I meet them in the office and home visits. And she starts telling me about this incident that had happened a day or two before, that she had been with her husband and they had started arguing in front of their son, and that the argument escalated to him starting to strangle her. He was strangling her in front of the child. She had bruises. She showed me. She had a hijab, so she was covered, and then so she took off her hijab and she showed me the bruises on her neck, and then I think she had some on her arms too, so he had grabbed her on her arms. And she said I couldn't tell anybody. She told me, you can't tell anybody. If you tell, what will happen? You can't tell anybody. Now, mind you, this is also when my interpreter is saying, no, Dawn, you can't tell anybody. You can't tell anybody. So I felt very frazzled. It was a stressful situation, and I worked to calm myself down and said, I have to tell, because I'm a mandated reporter and there was a small child present during this incident. So again, I'm kind of getting this pressure from both of these women, inappropriately from the interpreter, and telling me that I should not tell. So I knew in that moment that by reporting, which I had to do, and I wanted to do because the situation was not safe, that this was going to break the rapport with this client, that she was most certainly never going to see me again. So I informed her in that moment. I asked about safety. I asked if she could go home. I asked about a plan, if she had a plan in place. I asked her if we could help with resources, which she denied. She did not want help with resources. She did not want to know what her options were. She was not going to leave. And then I offered to follow up with her. So she said that she felt safe to return to the home, because also in these situations it's a cycle. So after the peaked violence, it would have probably felt calmer in the home. So she felt comfortable going home. She felt safe. But again, she implored that I do not call. And I again reminded her that I do call. I do need to call. And then I did actually call, I did call Child Welfare Services, and I also called my clinical supervisor for some additional support, which I'm going to talk about in a moment for all of you as well. And so I reached out just to get some feedback to make sure I'd handle the situation as best as I could. And I think if I could do it again, if I were in that situation again, I think I would work. And I don't know if I would have done it differently, to be honest, but I just really wanted to make her feel safe and wanted her to know that she was supported, and that calling child welfare services is really, in the most ideal situation, is to protect her family. And there's all these myths in immigrant communities that I've worked with, that if any sort of authority comes in, that their children are going to be taken away. And I've heard this over and over and over. And I've heard people say too that they haven't called because they don't want their child taken away. So if I had not said that, I would most certainly say, this is really, in the best situation, is to protect the family and is to protect your children. And I can recall asking her, does she want her child to grow up with this understanding that this is how a relationship is? And so I don't think she was really in the space for that conversation to be had. But so I called welfare services. They contacted me and we talked, and they went out, and then I followed up with the client, and she, of course, never called me again, and she did not want to see me ever again. I left a message letting her know she could see another counselor through the agency if she wanted to and did not have to see me, and that could follow up anytime with us. And I don't know what happened. And that's the difficulty of that situation. I do know that Child Welfare Services opened a case and said that they felt like they had done all that they could. And at least for that incident, it was closed within the month time, and that they felt there was nothing else that could be done in the home. But I don't know what happened to the family. And that part is what's very difficult for me, is not knowing. And that's the difficulty of the work that we do too, is that we don't always get the end of the story. The next case that I wanted to talk about was, I wanted to look at, there was something that came in. I'm just going to address this really quick before I go to the next case. Someone said that realizing that intimate partner violence can be between teens, and maybe that came, I did mention that is certainly something that could happen between teens as well, and that are incidents that we have seen in high school situations. And there's actually some really great programs out there for high school students to help them be aware of intimate partner violence. But absolutely, it is not something that's happening between people who are 18 and older. It absolutely can happen between teenagers who are either in high school, younger teenagers, or in early college years too. So that's definitely an important piece. The next case study, and if there are any other questions, please bring them up. And you're welcome to enter them in at any point. I'm happy to answer as I'm able. The next case study I wanted to talk about was regarding a client just a few months ago. I'd known her, we had seen each other probably about a year and a half ago for just a few sessions, and then she terminated. And I found out she terminated because she had moved to London to get married. Then she had returned to the United States with her husband. She is in her mid-40s. She's Afghani. She was settled in the United States several years ago, but had gone back to Afghanistan in 2003, 2004 to get married for the first time to somebody who she had known through her family. So she was then back in the United States after her second marriage in London, and she reached out to the organization that I work with and requested services again. And so we began seeing each other, and she was expressing symptoms of depression with somatic symptoms, with headaches, extreme headaches that would affect her ability to even work. So she was in psychiatric care with somebody through the agency, and then she's with me for counseling. And when we met, we were talking about trust. She kept telling me about trusting her new husband, but she wouldn't tell me about her first marriage. So we met several times before finally, interestingly, it was a very rainy day on Valentine's Day here in San Diego. And she, it's just an interesting coincidence that it was that day, but she finally shared with me that she had been a survivor of domestic violence, of extreme violence with her first husband, to the point of him, the incidents included neglect, there was psychological and emotional abuse. He was verbally very, very abusive. He was physically abusive. Several times he had tried to kill her while in the car. And we talked later about phobia she has still now in driving. But she told me I was the first person outside of her family that she had shared this story with. So I was sitting there. Again, I recognized that there was something going on because she kept talking to me about trust. So I knew perhaps there was something that was happening, something else that was happening that I wasn't fully aware of, I didn't know the details of. But in that moment, she started to say, there's so much I haven't told you. So that's when, in my head, I said, this is going to be big. I know this is going to be big. So I took a deep breath and said, you can share with me all that you feel comfortable sharing. Only share what you feel comfortable sharing. I'm not going to ask you to give me anything more than you're ready to give. And in that moment, she shared about her first marriage and the difficulty of the first marriage, and how she still now, this was several years since she's left that marriage, is still rebuilding her life. And I explained that that was understandable and that it's a very difficult situation, and it's understandable, all the feelings that come with it. Whatever she was feeling is understandable and normal. So over the course of several sessions, she told me more and more of the story, and she was safe, but she would tell me triggers. And so this is for those cases. So for example, if you have a student who is out in the field and maybe they're a survivor of domestic violence or intimate partner violence, but are no longer in the situation, but something happens that triggers them. So for her, it was whenever a family member or friend became pregnant, that all these memories would come back, because she had tried everything she could to have a baby in her first marriage, and realized after the fact that her husband was sabotaging any way he could. So if they'd gone to a doctor about fertility and the doctor said do XYZ, he would do none of those things. And for a long time she would blame herself. So we talked too about, really taking that blame, forgiveness for herself, in that forgiving her younger self who couldn't know she couldn't know. She trusted him. She had married him and trusted him. And that she wanted to believe that he was who he said he was. So spending that time really affirming her, and I spent a lot of time looking at her strengths and gifts and sharing that with me. And then we talked about, because she thought too that perhaps God was punishing her for some reason, that she wasn't having a baby because she had never become pregnant, or no, actually, she'd become pregnant several times but miscarried every time, and that she had miscarried because God was punishing her. So we talked a lot about that too, and her image of God. And ultimately, when we discussed her image of God, she said that the God she believes in is a loving, caring God who would not do this to her. So really having the conversation around a forgiving God and understanding that she was not being punished, and that this is a circumstance that was that the pregnancy was outside of her control, and then that the husband, who was being abusive, was contributing to that, to sabotaging that incident. So if there's any, or her ability to have a child. So again, if there's anything you'd like to follow up on, I have one question I want to look at here quickly. It's talking about immigrant cases. How do you resolve cultural differences in such a case? Okay, so I want to read that out. So when looking at immigrant cases, as I'm talking about for both of my clients, how do you resolve cultural differences in such cases? Is the question, so I'm going to assume that this means someone comes from a different background and the society they're coming from is accepting of this. And if that's not what you're asking, then please write and let me know what you're asking. I will say this. Even if somebody is coming from a culture where is quote unquote acceptable to be abusive, or like the treatment of women is very different than it is in the United States, what we have said is, or what I have said, what I've been educated to say as well, is that they are now in the United States where the standard is we are mandated reporters. So if there's a child or someone over the age of 65 involved, we have to share. We have to report that information, and that there are different standards and expectations of how a woman or a partner will be treated in the United States. And even if that cultural background is different, how do I want to make sure I want to say this? Like, it does not make it then okay in the United States to be abusive just because they're coming from an abusive situation. So I do think that there needs to be education both for the survivor of domestic or intimate partner violence, as well as for the abuser, to understand that the abuse is not acceptable. And I will be honest, I don't know that the system has always done the best job of providing that education. And actually, something I would love to do is to provide that education for those who are accused of abuse, because really helping them understand the implications of that abuse, and really helping them understand that it's not acceptable to treat their partner or their family members in that way, regardless of what their cultural background and expectations might have been. So if that does not answer that question, please write in and let me know. I'm going to read another one here. Let me look at this really quick before I say it out loud because it's longer.
Dawn, I'm happy to read it for you.
Okay,
Would that be easier? Okay.
Go ahead.
So my CPE program teaches students to offer an open hand or ask permission rather than immediately touching or grabbing a care recipient in distress. Mm-hmm. Students often complain that it's awkward, and we basically tell them tough. It makes the intervention safer for you and for your care recipient. We teach them to say, "Can I touch your shoulder in support?" Any thoughts or resources on refining our teaching around this? Any best practices for permission seeking with strangers in crisis?
I think that's great. It perhaps does feel awkward. Your students are right. Perhaps it does feel awkward because it's very natural to reach out and touch somebody. I think it could be of value to teach them, and you could do work around trauma-informed care. You could even have maybe specifically looking at trauma-informed care, but really helping students, and this is the work that I do too, is the people I'm working with interpreters too, is really helping them understand that it can make it worse for the patient or the person they're working with. So, and it can I would say that it could disintegrate rapport too. So it's not about how we feel, it's about how we're making the person we're sitting with feel. And it's about creating a safe space for that person So really driving home the point that we need to create, we need to create a safe space for them. So and then I know I only have about 10 minutes left, and I want to talk about self-care. So if it feels awkward for the student, then I think it's important for them to debrief. I think in general, it's important for them to debrief after these incidents, because it's very intense, right? I had somebody talking about sexual assault, like a really very difficult conversation around sexual assault through interpretation. And at the end, after the client left, the interpreter said, "Is it normal that I feel really weird right now?" And he said, "It's normal." It was a very uncomfortable conversation. So debriefing. So for your students, being able to come back and debrief, and I believe they have those opportunities, but really encouraging them to do so. Having that space, hopefully in the hospital setting or the setting that they're in, but then being able to go back and have, whether they maybe need to be in therapy, which is fine, which I encourage everyone to do, especially in the work that we do. But then self-care is so important. Really, and that's a term that's thrown around, I know, but really taking care of yourself, whether that's, my pastor has repeatedly told me that I need to take several hours each week where I'm alone, just doing something that I want to do and not what I should do. And I've had to think a lot about what that would be. And for me, that's really, I need to be out in nature alone and not talking to anybody. I hear all day people talking to me with their stories, which I'm happy to be a part of. But I need to, when my own awkwardness comes up or my own struggles come up, I need to be able to be in a space where I can deal with that so that I can be fully present to the patient or client without letting that get in the way. Learning to manage that sense of awkwardness is really important, or that sense of the sense of pain or struggle that comes up for people is so important. So they need to be able to either maybe talk about that in therapy, debrief with their educator, debrief if there's staff at the hospital they can do that with, and then take care of themselves, whether it's healthy eating, exercising, meditation, relaxing, all those things we hear about that are really important to actually do. So with a little bit of time left, if there are any other questions that come up, you're welcome to bring those up. I'm going to bring up again really quickly this shared screen so I can show resources, but then there was a question that had come in.
Yeah, I'll read that, Dawn, when you're ready.
Well, I'm going to pull up, go ahead, Claire. I'm going to pull up just resources because some of them were what we had talked about that would be valuable.
And I have a couple more to add. So
go ahead.
Here's the question that came in during the week. How to provide pastoral care to a mother whose child has been molested by an extended family member. The mother described this as more distressing than the death of one of her children and her own history of sexual assault. I met this mother in the context of a hospitalization related to drug and alcohol use. She expressed rage, but was not able to talk for more than a few minutes due to distressing emotions. I thought the situation might have some dimensions relevant to both presenters and would appreciate any insight either or both might have.
Claire, I'm going to yield to you right now since I'll let you start.
You want to take a breath? Okay.
Yes, so I could take a breath, exactly.
So some of the resources that I gave you were in direct response to this. So let me go there. So the first is the book, a very touching book by Jan Hinman. It's a book that is ostensibly written for children. It looks like a coloring book. However, I use this intergenerationally, particularly when I have a suspicion that one or both of the parents may have been molested as children, or as a diagnostic tool, because very often if you have a child that's being abused in a home and it is not discovered early on, it's because there's a family pattern that may or may not have been identified. This book does a wonderful job of facilitating that. The second one, called Please Tell, also helps to, back to your earlier point, Dawn, about this took a lot of courage, good for you. Please Tell underscores that. I find it interesting that it's put out by Hazelden, which is typically an alcohol and drug rehabilitation and treatment center up in Minnesota, Center City. And finally, a book written by a woman by the name of Beverly Engel. Beverly does phenomenal work around abuse in families. This one is particularly geared towards assisting the entire family in recovery. And I wanted to bring that to the attention of the person who wrote in. The other thing is, it was not a surprise to me at all, and I'll just say this because I think it probably won't be to you either, Dawn, that she was, the mother herself was involved in alcohol,
Right,
and drug use, that people self-medicate early on in response to memories they either have or have not had. So when you run into people who are in drug and alcohol treatment, there's often a dual diagnosis. The one gets treated because it's physical and obvious, but it's usually a somatization of the denial structure that somebody's involved in. One of the other resources that came up for me as you were speaking, particularly has to do with your surprise that you will have sometimes when you're dealing with people, and all of a sudden there's a disclosure of domestic violence or intimate partner abuse. Just for everyone to have this, it's a book title is Not to People Like Us, and the subtitle is Hidden Abuse in Upscale Marriage. And it's written by a woman by the name of Susan Weitzman. So it's kind of on the other end of the scale that you may be experiencing when you're working with the immigrant population. The mother, in the question of the woman who wrote in, I would attend to the mother in terms of helping her get her story distinct from her child's, because before she can do that, she's not going to be fully capable of addressing her child's. Along with that, I would help her find resources for her child's support that do not necessitate her being present. So a child therapist, sand tray therapy, something appropriate to help the child depending on the age of that child, distinct from getting the mom appropriate support for her own experiences. And then I'll hand that back to you, Dawn.
Yes, so thank you for bringing up that book, Claire, about, I'm forgetting the name exactly, but it couldn't happen to us.
Not to people like us.
Not to people like us, yes.
Yeah, I'll give you that resource when we get off.
Okay, so I just want to echo that I support what you said in that case, especially around drug and alcohol use. You're right, the self-medication that could be happening because of the abuse that somebody endured. And I just think, and thinking about the book that you offered, a very touching book too, and she even says in the title, a book for little people and big people too. Mm-hmm. So really the importance of the family work that needs to be done, so that it's not perpetuated, but that's not what you're going to be handling in that immediate moment necessarily. But again, like you said, really helping her understand her own experience versus the experience of her child. And then I know we're almost done, so I wanted to say a question had come in saying, may we have copies of your presentation, including the recording to use with our students? It's my understanding that because this is being recorded, that you will have access to this, and that we'll make sure that we get these resources to you all as well, so that you have them. So I want to honor everybody's time. We're at 1 minute, and again, if any questions come in, if you think of anything after the fact, please email Janelle, and then she will get that to us, and we can answer that next week. And then Claire will be speaking next week about grief, and then in 2 weeks, we will talk together about commonalities as well as differences that we see, and any other questions that come up. So thank you all for your participation today and the questions that you asked. You asked very great questions, so thank you so much. Okay, so we are at time, correct?
Yeah, I want to save this last comment.
For next time?
Yeah.
Okay. All right, because it is, yes, lengthy. So, all right, thank you. So for the last comment that came in, we will address that next time since we're at the end of time. Thank you all so much.